رقم كم الكلب هذا؟ آه، فاطمة.
40 40.
40. اوكي، ثانك يو.
السلام عليكم.
عليكم السلام ورحمة الله وبركاته.
دكتور أشرف، ازي حضرتك؟
أهلا
أخبارك
وسهلا،
إيه؟
يا مرحبا، الله يحييك. خلاص احنا نبدأ الآن، بسم الله.
لو نعرض الفيديو واحدة مرة بس يا فاطمة، لو سمحتي، وبنهايته نبدأ على طول.
خلاص، I'm ready. Okay. Okay. نبدأ. بسم الله
على
الرحمن
بركة الله.
الرحيم. بسم الله الرحمن الرحيم، الحمد لله رب العالمين، والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. Dear colleagues, respected doctors, ladies and gentlemen, السلام عليكم ورحمة الله وبركاته، وأسعد الله مساءكم بكل خير وبركة. First of all, I would like to welcome you here on the 40th session of the IMC Family Medicine Club. And this club has been started since many years. And the main objective of this club is to update you with the highest level of highly evidence-based medicine and the updates in the field of medicine in different specialties that touch the reality of our diversity of cases that we come across in our day-to-day practice as a primary care physicians and a family physicians, in fact. And today, ladies and gentlemen, we are going to spotlight on a very important topic, which is, again, one of the very common presentation and very common clinical entities that come encounter, but yet it's a real challenging. So we are going to talk about the update in the management of migraine. And as you know, migraine is a very challenging type of clinical entity. As we know, not all the headaches are migraine, and the challenge happens when we come encounter varieties of different types of headache that we have to sort it out, and also the presentation of patients usually not very classical, and we have to understand that there is a secondary causes of migraine that we have to sort it out to make sure that we are safely managing patients with migraine, and the treatment of acute versus preventive is very important part that we have to increase our competencies in this kind of regards. And then when to refer patient to the neurologist, so we have a certain scope. And of course, in the era of the expansions of the scope of family medicine competencies, we found ourselves standing in a position that we should work with a high level of competency in hand with our colleagues in different specialty, like the specialty which we are in concern today is the neurology departments and neurology colleagues. So definitely this is going to be a very interesting session. We are eager to hear from our guest speakers. We have Dr. Wissam Yemek and Dr. Saeed Al-Ghamdi, both of them they are neurologists, and we have Dr. Maisa Khalil, she's a family physician. And we will start by the first speaker, who is Dr. Maisa Khalil. She's a consultant in family medicine at the International Medical Center. She was graduated from Beirut Arab University, and then she received her special degree in family medicine from American University of Beirut. And she's going to talk today about the burden of migraine and the impact of the migraine as invisible disease on the patient's life, the quality of life, and even the burden on our healthcare system. I would like, on your behalf, to welcome all of the speakers, and I would like to thank the Saudi Society for Family and Community Medicine. Thanks to the Family Medicine Department at the International Medical Center, and a special thanks for AbbVie and FEXS, Multaqa Al-Khibrat, for organizing this wonderful opportunity for us to be together tonight. So without any further ado, I would like to leave the floor for Dr. Maisa. The floor is yours, Dr. Maisa. Thank you for being with us here tonight.
Assalamu alaikum. Thank you, Dr. Ashraf, for the kind introduction. It's my pleasure to be sharing today. I will share the screen now.
Yes, we can see the screen. Just full screen, please.
1 second. Okay, is it okay now?
Yes, clear.
Okay, so as I said, as Dr. Ashraf mentioned, I will be discussing the burden of migraine, which has a big impact as an invisible disease. This is my disclosure statement. And first of all, I'd like to list my outline. I will briefly go over the epidemiology of migraine, the diagnosis of migraine, and the burden of the disease. What are the treatment methods, the non-pharmacological treatment methods, how to manage migraine in special populations, how to recognize comorbidities, how to follow up on treatment response, and what are the indications for referral. As an introduction, we all know that migraine headache is a very common encounter we might see in our clinics. So today I will be first highlighting the burden of this invisible disease. The most recent statistics prove that headache disorders are the leading cause of disability worldwide among the non-communicable diseases. The prevalence of migraine per se increased from 721 million in the 1990s up to 1 billion in the 2019. And the age group affected, migraine ranked first in the 10 to 24 age group and the third among the 25 to 49 age group. So it was higher in the younger age group. The disability burden of migraine is measured by the dailies, and we can find that 5% of the dailies was accounted to migraine in the younger age group, whereas the dailies of the older age group was 3.7% from migraine. The dailies is the disability from a certain disease. It is a health metric measured by the addition of the years of life lost and the years lived with disability. This graph shows more about migraine globally. Migraine, as I said, is highly prevalent, affecting 1 billion people worldwide. The global prevalence reaches 14%, and it is the 6th most prevalent medical condition worldwide. If we want to clarify more, it affects 19% of women in the world and 10% of men, which means it is more affecting females. This is a detailed finding in the global burden of disease. The last one was updated year 2019. As we can see here, we have the leading causes of disability among the age group 10 to 24 years old. From the first leading 10 causes, headache disorders comes next, the second leading cause of disability. As you can notice, it is more disabling compared to depression, anxiety, and low back pain. So as an introduction to the diagnosis, we know how prevalent it is. That's why we need a very good and proper approach to get an accurate diagnosis. We all know migraine. I will just highlight briefly the typical presentation and then go further. So for the headache characteristics, it is typically unilateral, pulsating in quality with moderate to severe intensity. It is rarely mild in intensity. It is usually aggravated by routine physical activity and relieved by rest. And the typical duration ranges from 4 hours up to 72 hours if untreated, which means we have 3 days of headache, which is very disabling. What are the associated symptoms of migraine? It can include nausea, vomiting, photophobia, and phonophobia. Some patients might also complain of osmophobia, which is sensitivity to certain odors. 1/3 of patients with migraine have aura. And aura are symptoms that are reversible, neurological disorders, or symptoms, if you want to say. It lasts typically from 5 to 60 minutes. The most common aura are visual, but it can also be sensory, speech, or motor. And finally, we need to know if the patient has any prodromal or postdromal symptoms. Prodromal symptoms come before the headache. They can include mood changes, food cravings, or neck stiffness, and they can occur for hours before the headache starts. Postdromal symptoms come after the headache ends, which include fatigue, cognitive difficulties, or mood changes, and they might last for up to 48 hours, which are additional 2 days of disability. So how can we organize the phases of migraine? We need to know the prodromal phase followed by the aura phase if present, the headache phase, and then the resolution of the migraine, the postdromal phase. As I mentioned, 1/3 of migraine patients have aura. We need to know how to label the patient and with which type of aura. Usually patients with aura are more difficult to treat. They have a worse prognosis. That's why we need to label them from the start, and the treatment differs. So an aura can be either visual, sensory, speech, or motor. The most common is visual. It can include scotomas, fortification spectra, or vision loss. Sensory aura can usually include tingling or numbness on one side of the face, but sometimes it can also include the body. Speech aura may involve difficulty speaking, finding words, or understanding speech. And motor aura, although rare, it can sometimes happen with unilateral weakness. This is called hemiplegic migraine. How do we know it's an aura or a real focal neurological deficit? Usually it recurs before every headache. It is reversible and lasts from up to 5 minutes, from 5 minutes up to 60 minutes maximum. If more than that, it is not an aura. So as I said, we need all of these details, the history, the postdrome, prodrome, associated symptoms, and aura. It's really difficult from the first time to get all of the answers. That's why we usually ask the patient for a headache diary, which is a key to accurate diagnosis. You can simply tell the patient what the questions you want, and on follow-up visit, ask for the answers, or you can ask them to fill up a diary. I am putting here a diary from the Federation Headache, from the European Federation Headache. It is one example of diaries that has 16 questions to be filled by the patient. The first questions are for the day of headache, the time, duration, how many hours, and the side of the headache. The second part includes question about the nature of pain, the severity, whether it affects the daily activities or not, what are the aggravating and relieving factors, and what are the associated symptoms. They can be answered on multiple headache attacks. And last, we have questions about more associated symptoms. And you can see the last part is about medications. What type of medication, which strength, how many times the medication was taken, and how many types of medications were used by the patient to treat the headache. So after getting the needed history and details, these are the steps for diagnosing migraine. We have the medical history we want from the diary the patient had filled. Let's check the diagnostic criteria to confirm the diagnosis of migraine. We need to put in mind the differential diagnosis, perform a proper physical exam, and then reach the final diagnosis. So this is the criteria, the International Classification of Headache Disorders criteria. I will read them loud to know what is the real criteria to diagnose migraine. First of all, we need to have 5 or more attacks fulfilling the following: headache attacks lasting from 4 up to 72 hours when untreated or unsuccessfully treated. Headaches that has 2 or more of the following symptoms: unilateral location, pulsating quality, moderate to severe pain intensity, and aggravation by physical activity. The duration of the headache includes 1 or more of the following: nausea and or vomiting, photophobia and phonophobia. And finally, the symptoms are not better accounted by for another ICHD-3 diagnostic criterion. So if we have these criteria, we ruled out the other differential diagnosis. This is migraine. And then after labeling the patient as migraine, we need to classify the patient as having episodic migraine or chronic migraine. And this depends on the number of days per month of headache, days, not attacks. So for episodic migraine, it is when an individual with migraine has less than 15 headache days per month. And for chronic, it is 15 or more per month for more than 3 months, on which 8 or more days meet the criteria. So sometimes we can have attacks that do not meet the criteria, but we will rely on the diagnosis I just mentioned. The statistics of migraine show that episodic migraine is more common than chronic migraine. 91% of patients with migraine are episodic cases, only 9% are chronic, but those with episodic are also classified further into low frequency episodic migraine or high frequency. I will tell you why. Low frequency migraine, episodic migraine are those who have less than 8 headaches days per month, and high frequency are those who have 8 up to 14 headache days per month. The importance is also for the treatment plan and for the prognosis, because it was found that the disability caused by high frequency episodic migraine was as bad as the disability caused by chronic migraine. So we need to know which class the patient is in. So what is the differential diagnosis of migraine? We all know that migraine is a primary headache. We need to rule out secondary headaches, and still we have other primary headaches in mind. So by history and by physical exam, we can know if we have other primary headaches like tension type headache, cluster headache, or trigeminal cephalalgias. And to rule out secondary headaches, it is really important to look for diagnostic questions and specific findings by the physical exam. Sometimes we need to investigate, but I will let you know what are the diagnostic questions or findings. For example, if we have sudden onset, severe headache, thunderclap, worst headache ever, this is a sign of intracranial bleed, which is a very alarming or red flag that you need to send the patient to ER. If you have a new headache after the age of 50, so the patient was not labeled or not complaining of headache before the age of 50, this is also alarming for investigation. If the headache is progressively worsening and the headache has systemic symptoms, fever, vomiting, weight loss, any focal neurological deficit, these are indicators of a secondary cause. We need to do physical exam, we need to investigate and treat the secondary cause. That's why I repeat and say we need to look for the key differentiating features, look at the criteria, take a very good history and a very good physical exam. When in doubt, when you have a patient in the gray zone, it's not very typical, you think something is wrong, you can refer to a headache specialist or a neurologist for better evaluation. So after reaching the diagnosis, we need to treat, but before that, I need to highlight the burden of the disease to know what we can do to such cases. First, I will say what are the WHO disability categories. So it starts with class 1 as the least disabling disorder up to class 7, which is the highest disabling disorder. You can see that severe migraine lies in class 7. This means that the disability caused by severe migraine can be as bad as having active psychosis, dementia, and even quadriplegia. The migraine disability assessment also varies between males and females. As I mentioned before, it is more common and more prevalent in females. The mean duration of attacks is also higher in females, reaching up to 36 hours of headache compared to 28 hours in males. It is more likely to recur in females. 12% of females have a grade 4 disability. MIDAS is the migraine disability score. So 12% have a grade 4 disability in the females, whereas only 9% have disability grade 4 in the males. And finally, it was found that 24% of females with migraine compared to 18% of males received anxiety and depression medications as a comorbidity from migraine. Next is this graph that shows the impact of migraine on the mental well-being. As you can see, 7% of respondents with migraine developed also anxiety, 9% developed depression, and 21% developed both anxiety and depression. You can also notice that moderate to severe disability affected 43% of patients with migraine and anxiety, and almost half of the patients with migraine and depression. Now I'm highlighting the impact of migraine on work attendance and performance. It has significant impact on work performance with people having 75% of people believing that migraine affects their professional life. An average of 4.6 days of work were missed each month because of the migraine headache. 13% of the respondents reported reducing the number of hours worked due to migraine, and 29%, about 1/3 of the patients agreed that they would be more successful in their career if they did not have migraine. So 26% of those with migraine feel that colleagues do not understand them, and up to 24% feel judged for taking their days off because of the migraine headache. Finally, here is the impact of migraine on family life and relationships. Up to half of the people with migraine report missing family activities. It can also cause difficulty in relationships, with 30% reporting that their spouse does not really believe them about their headaches. Finally, patients frequently report a significant impact on personal and family finances, with 33% reporting about long-term financial security. So I think this is enough information about the prevalence and the burden and the impact of the disease. Now I will quickly review the treatment methods. I will not dig deep into it because my colleagues, Dr. Wissam and Dr. Saeed, will discuss it furtherly. The treatment options include acute medications when needed, preventive medications also when indicated, lifestyle changes, and self-help strategies that are taught to the patient to do himself or herself to treat the migraine headache. So what are the acute treatment methods of migraine? First line are usually NSAIDs, over-the-counter NSAIDs like ibuprofen, naproxen, aspirin. We encourage early treatment at the onset of migraine for best results. When the severity is very mild, we advise the patient to take the painkiller as soon as possible. Now, if NSAIDs are ineffective, we go to the second line, which are triptans. The options include sumatriptan, rizatriptan, zolmitriptan, and others. We need to educate the patients on their proper use, proper dose, and potential side effects. We can combine triptans with NSAIDs for enhanced efficacy. Third line options for patients who don't respond to or cannot take triptans. For these patients, we consider gepants or ditans, gepants like rimegepant and ibrogepant. These newer medications have the advantage of fewer cardiovascular contraindications compared to triptans. And finally, on top of these three treatment options, we give adjunct treatments, for example, antiemetics like metoclopramide or domperidone, which can be added for nausea. There are some studies also that prove it can also help abort the headache attack, even if given IV in the ER. Some other patients may benefit from non-pharmacological approaches such as cold and heat therapy or relaxation techniques. So for prevention, there are several proven drugs, but when do we start prevention? This is the important part. First of all, we need to assess the need. We consider prevention for patients with 4 or more migraine days per month, or for those with significant disability despite acute treatment, or those who have contraindications to acute medication. So when we know we need a prevention, we need to select because we have a lot of options. We choose based on the efficacy needed, on the side effect profile, on the comorbidities of the patient, and the patient preferences. Some of the options include propranolol, topiramate, and amitriptyline, but there are a lot others. When we select the medication, we usually start low and go slow by titration. After follow-up, we monitor the effectiveness and adjust when needed. We usually need follow-up, close follow-up, every 4 to 6 weeks, and then later on, when well controlled, every 2 to 3 months to monitor the response. So these are the pharmacological treatments. Now I will discuss the non-pharmacological treatments because they really play a role. We need to emphasize the strategies that can be taken by the patient himself. So we all know that migraine attacks can be triggered by poor sleep, by poor diet, by some sedentary lifestyle, stress, and others. So we can encourage sleep hygiene, we encourage consistent sleep schedules, and we need to address any sleep disorder like insomnia a patient might have. We need to identify and avoid triggering foods, and we need to maintain a regular meal because we all know that fasting can trigger a migraine attack. We need to promote moderate aerobic exercise to reduce migraine frequency and to teach them stress management by relaxation techniques, mindfulness, or CBT sessions. We can integrate these approaches with either the abortive or the preventive measures or treatment measures of migraine. And we also need to tell them to write these down in their diaries to know what is triggering them, what is relieving them, so that they can notice it because sometimes it is unnoticed by the patient. Recognizing the risk factors for migraine can also play a role in the treatment and prevention. We actually have nothing to do in the non-modifiable risk factors like family history, being a female, the monthly hormonal fluctuations, the age, and the socioeconomic status, but we can act on the modifiable risk factors. For example, obesity, sleep apnea, smoking, the number of caffeine per day, and others. All of these can impact the frequency and the severity of migraine attacks. There are studies that prove this, so we can play a role here, treat any risk factor. And as you can see, the last modifiable risk factor is poor acute attack management, unmet needs, which will be discussed by Dr. Wissam after I finish. So now, how do we manage migraine in special populations? First, for older people, we need to consider the comorbidities, any cardiovascular disease, any other problem, dizziness, frailty, potential drug-drug side effects, drug-drug interactions. We need to be cautious with triptans and those with cardiovascular risk factors, and NSAIDs might be contraindicated for gastrointestinal bleed or renal issues. So we need to choose the medicine wisely. For pregnant women, we have a lot of restrictions. Usually for abortive attacks, we only take acetaminophen, paracetamol. And for preventive medications, we prefer not to keep the patient on any unless there is a discussion with the neurologist and obstetrician if the case is very severe and bad. We need to rely on the non-pharmacological lifestyle advice with the pregnant women. For children and adolescents, the presentation is different. We need to know that. It's not as typical as adults. Ibuprofen is the first-line treatment for acute attacks. Topiramate and propranolol are the options for prevention, and we also enhance lifestyle modification and stress management. And finally, for menstrual migraine, it is a very common type of migraine. We can consider hormonal influences. We can consider, many prophylaxis with NSAIDs or triptans around the menstruation, and before the menses starts, we can give NSAIDs or triptans to prevent the attack or treat it early on. And for some, we can consider hormonal contraception, which can reduce the attack frequency. Now I will be discussing the comorbidities that we need to look for in patients with migraine, because this can also affect the quality of life and impact the disability of the patient. Comorbidities can aggravate and complicate migraine. We need to screen patients for any psychiatric disorder like depression and anxiety. And if the patient meets the criteria, we need to initiate a treatment. Second, we need to look for any sleep disorder like apnea, insomnia, which can also aggravate migraine attacks. By the way, we have a closed vicious cycle here. Sleep disorders, for example, apnea, can trigger migraine, and migraine itself can affect the sleep and cause a sleep disorder. So this is really complicated. We need to break the cycle at some point, treat both the sleep disorder and the migraine disease. Finally, we need to screen for any pain comorbidities like fibromyalgia, like chronic neck pain. We also need to treat them with any acute or preventive therapy so that the migraine attacks are also better. After setting the treatment plan for each patient, we need to ask for follow-up visits to assess the success of the treatment we have started. So to monitor treatment response, we need to perform initial follow-up in 4 to 6 weeks after starting your new treatment, whether abortive or preventive treatment. We need to assess the effectiveness, the tolerability, and the adherence, and we can know the answer by diaries or using the MIDAS score, whether the patient has disability from the migraine attacks or not. Then we need ongoing monitoring every 3 to 6 months to confirm if the patient is feeling better or not. We can, at one stage, adjust the treatment. If the response is suboptimal, we can change the class, we can increase the dose. The options are plenty. And at one point, if we don't find any response, we can refer to a specialist. And for long-term management, we need to regularly reassess the need for preventive therapy, because some patients, after a period of good control, we can taper down the preventive therapy and get them back on abortive therapy when needed. And we always need to emphasize the importance of lifestyle modification. Each visit, look for the triggers, counsel again, give lifestyle advice changes, and so on. This is another example of a headache calendar, not a headache diary for screening. It is also issued by the European Headache Federation. As you can see here, we have the months of the year, the days of the month. The patient has to record when the patient has migraine and when was it gone, what was the medication the patient was taking, and so that we can evaluate it on follow-up and check the response. Why is it useful? Why is the headache calendar useful? It will track the medication, not any additional factor. For example, we can notice it is menstrual. We can notice it is like during weekends when the sleep cycle is different, in vacations, during stressful times. It can give us a hint if the history is not very clear from the patient. So what are the benefits of consistent tracking? It is actually not boring. It is very beneficial. We identify the pattern for each patient. We optimize the treatment based on what we find. We monitor the progress. So we find like 10 headaches per month, and then 5, and then 2. So we know we are improving. It is objective, not subjective. And we also empower self-management. Now, this is my final slide. It is the indications for referral. When should we refer a patient with migraine? Number 1, it is when we have diagnostic uncertainty, a patient with multiple gray zone, maybe some focal deficits, not very typical, atypical presentation. We need to know if it's secondary or not. We can refer the patient for better evaluation. When we have treatment resistance, we have tried multiple preventive or abortive medications with no response. When the cases are complex, elderly people, pregnant ladies, as I mentioned, and when we consider advanced therapies that we cannot do, for example, using botulinum toxin, Botox, for prevention, CGRP monoclonal antibodies, and neuromodulation devices. I need to mention that after referring the patient, getting the neurology consultation, the new treatment, and the treatment plan, when the patient is back to good control, the patient can get back to the family medicine clinic and get the regular follow-up needed.
All right. Thank you so much, Dr. Amaisa, for this wonderful presentation. You have highlighted everything about migraine. It was a real presentation that engaged the family medicine from the moment receiving the patient with clinical symptoms all the way to the diagnosis and differential diagnosis, and then putting the proper management and identifying the risk, and then going all the way to the referral and maintaining the continuity of care of getting the patient back to you again as the final statement you have mentioned elegantly. So now we are in the era of collaborating with different departments. So we always try to communicate and coordinate in order to have the patient moving from one level to another without any kind of turbulence. So this kind of understanding between family medicine and different specialty is very important to make this objective happen. So thank you so much, Dr. Amaisa. And now, ladies and gentlemen, I would like to introduce our next guest speaker, who is well known, Dr. Wissam Yamak. He's a neurologist with a specialty in epilepsy and clinical neurophysiology from the American University of Beirut. He joined the neurology department at IMC in October 2021, and we are really very privileged to have him with us, supporting the family medicine and participating with us in different areas of clinical educations and continuous medical education. So Dr. Yamak has a number of publications and peer-reviewed journals, and he will be discussing the unmet need and the new modalities in the acute management of migraine, which is a real important, challenging issue for us as a family physician in primary care. So thank you, Dr. Wissam, for being with us. Looking forward to hear a very interesting presentation to us. Thank you.
Assalamu alaikum and good evening, everyone. I'm really glad to be part of this meeting, and I'd like to thank you, Dr. Ashraf, for this invitation. I'd like to thank AbbVie and all the organizers, and I hope my lecture will be informative and to the point. And this is the outline that I'll be going through in a while, starting with the pathophysiology of migraine, moving to the goals that we need to achieve from an acute migraine treatment, and then discussing the results of some studies emphasizing the unmet needs with the current acute medications of migraine, and ending with a definition of an effective treatment of a migraine attack and listing the currently FDA-approved anti-CGRP drugs. Now, understanding the pathophysiology of migraine is very important, because if you know the pathophysiology of a disease, then you can work to find a treatment that targets the root cause of that disease. Over the past 40 years, multiple theories were postulated. And until 10 years ago, it was thought that the pathophysiology of migraine is related only to vascular changes, including vasodilatation in the meningeal blood vessels mediated by the serotonin receptors and release of nitric oxide. And this is why migraine-specific medications were developed in the past to target serotonin receptors, such as the triptans, which are serotonin receptor agonists that induce vasoconstriction and thus helping in relieving the pain associated with an acute migraine attack. But now we've got to know that migraine results from an interplay. It's not just a result of vasodilatation of blood vessels in the meningeal area. It's an interplay between the neuropeptides and the neurogenic inflammation, leading to activation to what we call the trigeminal vascular system, which is a key player now in migraine. So what is the trigeminal vascular system? What do we mean when we say trigeminal vascular system? From its name, it consists from the trigeminal nerve and its branches. And this is the trigeminal nerve. It has 3 branches, the ophthalmic, the maxillary, and the mandibular. And the ophthalmic branch is very important because it is the same part of the nerve that supplies the meninges and the blood vessels inside the meninges of our brain. And the vascular part are the blood vessels. So it's a neurovascular disease. The whole story starts here at the level of the blood vessels and the meninges with the release of neuropeptides and inflammatory mediators. And among the most important neuropeptides are the CGRP. This will lead here to, I think the picture might be complicated, but I will try to dissect it into an easy way. What happens in migraine, it starts the release of neuropeptides here leading to inflammation. And this inflammation will lead to sensitization of the ophthalmic division of the trigeminal nerve reaching to the trigeminal ganglion. And this is called the first order neuron. When this part of the neuron is sensitized, it will lead to sensitization of second order neuron that go up from here, from the trigeminocervical complex, reaching the thalamus. What is the trigeminocervical complex? The nerves that supply the skin in the scalp area behind the ear are supplied by the upper cervical spinal branches, C1 to C3. And the combination between the trigeminal nerve that supplies the anterior area of the head and the upper three cervical spine from the posterior part, they converge here at the trigeminocervical complex, and they send second order neurons to the thalamus. The thalamus is the gateway to the cerebral cortex. Everything going to the cerebral cortex from the peripheral system passes through the thalamus and then diverges to the cerebral cortex. And from the thalamus here to the cerebral cortex, it activates what? Multiple areas in the brain, including mainly the somatosensory cortical area. And this will lead to the cutaneous allodynia. What is allodynia? Allodynia is the perception of a non-painful stimulus as painful. And for example, if you touch the scalp, you should not feel any pain. But in this case, if you touch the scalp, you will feel a severe pain. This is called cutaneous allodynia. And this activation will lead to this hypersensitivity in the skin, will lead to the visual symptoms, the photophobia, the auditory symptoms, the phonophobia, and the motor symptoms, the fatigue, etc. And then the thalamus does not activate only the cerebral cortex. It has a feedback pathway that activates the hypothalamus, and from the hypothalamus back to the same area here to activate the meningeal nociceptors in the meninges, leading again to vasodilatation and to the migraine headache or cephalic allodynia. Now the allodynia is inside the brain. So we have two types of pain and headache. We have the cephalic allodynia, the headache itself inside the brain, and the cutaneous sensation. And a lot of patients describe this. They say, if I touch my scalp as if it's boiled. So this is the pathway of the whole migraine pathophysiology. I will add one point, something called the cortical spreading depression. The cortical spreading depression is one theory that was considered in the past to be a primary cause of migraine, but now it's considered as a part of this whole phenomenon. The cortical spreading pathway means that there is a cortical wave that spreads over the cortex and at the same time leads to the stimulation, to the initial stimulation of the release of neuropeptides, among them the CGRP, and now it's considered the cause of the migraine aura. So the migraine aura starts with a cortical spreading depression, and then it activates the whole circuitry. So now moving to the goals. So what are the goals of the acute treatment of a migraine attack? As a common sense, what do we need from a medication? We need three things: high efficacy, safety, and tolerability. And these were defined in the 2019 American Headache Society consensus position as follows. A patient should reach a rapid and consistent freedom from pain and associated symptoms without recurrence. He has to be able to restore his function with minimal need to repeat dosing or rescue medications, having optimal self-care and reduced subsequent use of resources such as visiting the emergency departments, the healthcare providers, or the need for infusion of medication infusions, and of course with minimal or no adverse events. So are the available medications providing these needs currently? Obviously not. Why? We will see this in the next slides. Here I will show you the results from a cross-sectional observational study conducted in Italy that evaluated all drugs regularly taken by 300 primary headache patients between October 2013 and December 2014. The diagnoses were based on the diagnostic criteria of the International Classification of Headache Disorders, and patients were divided into two groups, those with chronic headache and episodic headache. Chronic headache, as Dr. Maisa said, patients who experience at least 15 or more headache episode per headache days per month, and episodic headache patients with less than 15 headache days per month. And this diagram will show us that almost all patients in both groups were taking acute medications. And the most commonly used medications, as you see here, were NSAIDs and triptans. But triptans were more used with the patients of chronic headache, 65% of them, compared to 37% of episodic headache to use triptans. Of course, among other medications, opioids, muscle relaxants, antiemetics, and combination of analgesics. Sorry. It was also found that migraine patients were using multiple medications, as shown in this diagram. You can see here that patients with chronic migraine were taking 3 to 4 medications in the acute attack, and patients with episodic migraine were taking more than 2 medications specific for migraine. And even when we check the whole number of medications, including the antiemetics and others, they were taking 5 or 6 medications in the acute attack. Now, this acute medication overuse is associated with significant risks, including, as you know, especially with NSAIDs, kidney damage, liver impairment, GI bleeding, hypertension, and cardiovascular events. And very important to know the development of what we call the medication overuse headache. So what do we mean when we say medication overuse headache? It is the development of a new type of headache or a significant worsening of a pre-existing headache in association with medication overuse. And there are diagnostic criteria to really diagnose a patient has a medication overuse headache. Headache occurring on more than 15 days per month in an individual with a pre-existing headache disorder, regular overuse for more than 3 months, the duration of 1 or more treatments that can be taken for acute and or symptomatic treatment of headache, even simple analgesics like paracetamol. And these medications should be taken for 10 or more or 15 or more days, depending on the medication. For example, opioids or triptans, if they are taken for more than 10 days per month, they have a high propensity to lead to medication overuse headache compared to NSAIDs and paracetamol that need more than 15 days to trigger a medication overuse headache. And of course, the diagnosis should not be better accounted by another diagnostic criteria. So it's very important to recognize medication overuse headache in patients with frequent headache attacks. We have to explain to them the need for medication withdrawal and maybe starting a preventive treatment. And we should tell them that symptoms during withdrawal may worsen before improving. So it's important to know that over half of people with chronic migraine that is presenting for more than 15 days of headache per month have medication overuse headache and revert to an episodic migraine type after drug withdrawal. So many individuals do not improve after drug withdrawal. And in this case, medication overuse headache diagnosis may be inappropriate in these patients because these patients might have real chronic migraine. Individuals meeting criteria for both chronic migraine and medication overuse based on the International Headache Classification should be given both diagnoses. Now, if we look at this study called the Cameo study, the Chronic Migraine Epidemiology and Outcome Study, it's a large epidemiological longitudinal web-based study that identified respondents who met the modified international classification of headache disorder, including episodic and chronic migraine. It was designed to characterize self-reported headache symptoms and severity in a sample representative of the US population. It included more than 16,000 patients. The analysis evaluated results from about 12,000 respondents with migraine on current acute prescription treatment or OTC medication users. They found that acute medication overuse was present in 17.7% of the patients. And they found also that it was clear that among those patients with overuse of medications, the associated comorbidities were more prevalent, including the major depression, anxiety, and moderate or severe disability. So the impact of drug overuse and drug overuse headache is highly important. And in the same study, I can show you that 60% of the respondents with migraine reported at least one unmet acute treatment need. And these included most commonly moderate or severe disability. This means 70% of patients who took the acute treatment, continued to have a moderate or severe disability. And 60% of them were dissatisfied with the treatment, with the result, with the efficacy of the treatment. 11% of them reported having cardiovascular events, including angina, MI, intermittent claudication, stroke, and TIA. And 10% have excessive opioid and barbiturate use, because the initial medication was ineffective. And 8% necessitated the visit to the ER to receive an IV infusion. So all of those needs are not met with the current medication. Now, to emphasize the concerns regarding the side effects of acute migraine treatment, which are mainly the NSAIDs and triptans, I will share with you the results of data collected from 1,160 self-completion questionnaires received from people in the United States who met the International Headache Society criteria for migraine as part of the National Family Opinion Household Panel. The survey addressed headache management, medication-related adverse effects, and adverse effect impact. In this survey, 67% of people with migraine delayed or avoided taking their prescription medication. Why? Due to concerns about adverse events. So about 2/3 of the patients were afraid from taking the medications because of the fear of adverse events. And this had a significant impact on those people who frequently reported increased severity of pain when they did not take the medication. 60% of them reported increased intensity of the pain, expanded duration of the migraine attack, the need to lie down, and about a quarter of the patient needed to cancel their social activities or reported suboptimal performance at school or work, or even to be abstinent from work. So now if we want to talk specifically about the unmet needs and the acute treatment with triptans based on clinical observations, 34% of patients taking triptan reported inadequate response. 43% have treatment emergent adverse events. 30 to 40% reported recurrence of the headache after a few hours of the intake of the medication. And of course, these medications are contraindicated in patients with cardiovascular problems. And it's very common with the triptans to revert to a medication overuse headache when they are taken in large quantities. In this study, with the MAST study, the Migraine in America Symptoms and Treatment Study, which is a baseline web-based survey conducted between October 2016 and January 2017, it collected detailed information regarding patterns of medication use in a stratified random sample of US patients with migraine, collecting about 15,000 patients. The analysis evaluated past and current triptan usage patterns and rates and reasons for discontinuation. They found that only 37% had ever used a triptan, and only 15.9% were current user. This means that the discontinuation rate for older triptans was almost half, 55% of patients were stopped taking triptan. And the reasons for oral triptan discontinuation was mainly the perceived lack of efficacy and the side effects from the medication, among others. And the most common adverse effects that led to discontinuation of oral triptans were dizziness, nausea, and fatigue. Dizziness, nausea, and fatigue. And they found that 47% of oral users reported at least one triptan sensation symptom. And this is a common term. Triptan sensation symptom include paresthesias, flushing, tingling, neck pain, and mild transient chest tightness. And this another study reporting the triptan refill rates and switching patterns between other acute medications from the I3 Invasion Data Mart, which is a large US pharmacy claims database. Retrospective analysis identified 40,000 patients receiving new triptan monotherapy prescriptions from 2001 and 2005. Prescription refill information was gathered for 2 years for each patient, and persistency was defined as sustained refills of the index triptan prescription, regardless of the duration between refills. Sorry. They found that almost 54% of the triptan users received no consecutive refill of their index triptan, as I said before. And nearly 40% of those patients were then treated with opioids or barbiturates at the time of the first refill. And you all know the long-term side effects of opioids. So what is the definition of an effective treatment of a migraine attack? Now, according to the European Headache Federation consensus on the definition of effective treatment of a migraine attack and of triptan failure, they defined an effective treatment of a migraine attack by reaching within 2 hours from intake of the drug and maintaining for at least 24 hours a well-being status, as defined by all the following together: improvement of headache from severe or moderate to mild or absent or minimal disturbances due to migraine-related non-pain symptoms, that is the sonophobia, the phonophobia, the nausea, the vomiting, all the other non-headache associated symptoms, non-painful symptoms. And the third point is no meaningful drug-related adverse events. And these are mainly the 3 goals that we need from any acute medication. And they defined a triptan responder, the one who responded to triptan, an effective attack treatment in at least 3 out of 4 consecutive attacks. And those who don't fulfill this criteria are considered triptan non-responders. And it depends. If they failed 1 triptan, they are considered triptan non-responders. If they failed 2 triptans, they were considered triptan resistant. And if they failed 3 or more triptans, they were considered triptan refractory. And of course, there is a 4th category, which is triptan uneligibility, those patients who have cardiovascular risk factors. From the beginning, we don't give them triptans. So moving to a very short introduction about the CGRPs. As I said before, the CGRP is a key contributor to the trigeminal nerve pain and inflammation of migraine, and it is where the whole cascade starts. So targeting this CGRP, whether the receptor or the CGRP molecule, will help a lot in reducing the migraine attacks and severity. CGRP inhibitors are drugs that block CGRP from binding to CGRP receptors. And we have nowadays 2 classes of these medications: the monoclonal antibodies, which are large molecule drugs given as self-injections via an automatic pen every month. We have many medications now, 3 medications. And we have 1 medication that's given intravenously every 3 months. A patient should come to the IV clinic in the hospital every 3 months and take the medication for 30 minutes. And we have the small molecule CGRP receptor antagonists that block the receptor itself. And these are the GPANTs. These are taken mainly by mouth orally. So anti-CGRP drugs are the first class of migraine-specific medications that does not have a vasoconstrictive action, and this is very important in contrast to triptans, better efficacy, fewer adverse effects, and possibly longer period of activity than triptans. And these are the FDA-approved anti-CGRP drugs nowadays. As for preventive migraine, we have 3 medications approved, given as a subcutaneous injection every month. We have the adalimumab, the galcanezumab, which are available in Saudi Arabia, and the fremanezumab. The IV is the eptinezumab, which is taken every 3 months. And we have now the oral preventive therapies. The orally approved are the atogepant, the Equipta in Saudi Arabia, and rimegepant. And we have also the nasal zavegepant. For the acute migraine treatment, we have 2 oral medications now, the rimegepant and the ubrogepant, the Ubrelvy, and nasal zavegepant. These 2 medications are available in Saudi Arabia. Concerning the common adverse effects, of course, the injection site reactions, pain, erythema, pruritus at the injection site for monoclonal antibodies. But honestly speaking, okay, from my experience with all my patients, okay, I have never seen any patient complaining of any injection site reaction. Gastrointestinal issues, nausea, constipation, and dry mouth, particularly with oral medications, and hypersensitivity reactions like any other medication. And here I reach the end of my lecture. Thank you. We'll continue at the end with the case discussion, inshallah.
Assalamu alaikum wa rahmatullah.
Okay, thank you so much, Dr. Wissam. And we would like now to move to the third speaker, Dr. Saeed Al-Ghamdi. Dr. Saeed Al-Ghamdi is a consultant neurologist. He's assistant professor of neurology and internal medicine, College of Medicine, King Saud bin Abdulaziz University for Health Science in Jeddah. So Dr. Saeed is going to talk about epregepant in a clinical trial. So thank you for being with us here, Dr. Saeed. And I'll just like to leave the floor for you.
طيب, Bismillah ar-Rahman ar-Rahim. Am I clear? My voice is clear?
Yes, it's clear, and the screen is clear, but we need a
يعطيكم
full screen.
طيب, sure, inshallah.
Thank you.
طيب, Assalamu alaikum wa rahmatullah. It's a pleasure and honor to be among you, distinguished colleagues, and also among all the audience. I'm quite happy. I see a huge number of attendees. I'll just go back here. I'm sorry. I skipped a few slides. So I understand my colleagues has thoroughly discussed what is migraine, how does it present, and then discuss what is acute migraine and the role of acute treatment, whether it's triptan or others. I'll focus on the new modalities to treat these acute migraine with again the fancy new drugs that everybody's talking about now. It's the anti-CGRP. Specifically, I'll discuss a couple of trials that secured the approval for epregepant, which is an oral anti-CGRP, small molecule, that is now approved for treatment of acute migraine headache. These are my disclaimers related to AbbVie, and this is related to myself in relation to AbbVie and other companies. So I'll discuss a couple of trials. The Prudorm trial, which as the name implies, discuss the efficacy of epregepant as the only approved drug to treat prodrome symptoms, and we'll go what is prodrome, and then we'll discuss the Achieve-1 trial, and we'll see how did that reflect in international societies' guidelines, and I'll present a single clinical case. I'll probably leave the clinical case at the end when we discuss it with the other colleagues. So I just need, here we go. So the Prodome trial, it's a phase 3 trial, double blind randomized trial, placebo-controlled, that compared placebo to epregepant as the active ingredient in this trial. in patient with acute headache migraine. So I'll skip that. The prodrome, I'll just explain what is the prodrome. The prodrome, I don't want it to be confused with the aura. The aura, we all know what is the aura. The prodrome is more of symptoms that most, not all, but most migraine patients will manifest probably hours, sometimes 1 or 2 days before the headache. With these symptoms, most of these patients can predict that they're most likely will develop a headache within several hours or next morning or the day after. So the most common thing is being sensitive to light, neck pain, fatigue, sensitive to sound, and dizziness. These are the most prodrome symptoms that can persist for several hours, sometimes a day earlier before the headache happens. The most common one of them is the sensitivity to light. As I said, it's a multi-center randomized double-blind control trial with only including adults older than the age of 18. To qualify to be a study subject, you have to have at least 1 year history of migraine with or without aura. You should have at least 2, but maximum 8 attacks of moderate to severe migraine headache per month in the last 3 months before the screening. Each one, to be eligible, this will make you eligible as a migraine patient who probably need an acute treatment. But to qualify for this specific trial, you also have to have at least 2 qualifying prodrome events, which I described earlier, with the sensitivity to light, neck pain, fatigue, and etc. So the screening period takes about 60 days. They record plenty of prodrome symptoms to 3 to 16 qualifying events. It should be, as I said, it should happen within 1 to 6 hours before the event, and it should be happening in more than 75% of the events. Once you're qualified, you're going to be randomized either to take placebo or aprogepant 100 milligram, and then because of that attack, and then there is a 7 days washout where nothing is taken, and then you can repeat it in another randomization with a second prodrome event. You take aprogepant again or placebo, and you probably can see the crossover pattern in this study. So the primary endpoint, which is important, is not only being better, but the absence, complete absence, which is headache relief of moderate to severe intensity headache within 24 hours after the dose. So basically, you have a prodrome, you did not have the migraine headache yet, you take the medication with the hope that you will not have the headache at all. The secondary endpoint is absence of this same headache, moderate or severe, but to more extended period rather than 24 to 48 hours, and being able to function very well in the next 24 hours after the prodrome, and no headache of any intensity, whether mild, moderate, or severe, within 24 hours. These are secondary events, or secondary endpoint, I'm sorry. So at baseline, the patient matched very well in terms of age. As we expect, most of them are females, and they matched very well. Most of them were white. Whether they are Black Americans or African Americans, Asians, they match very well. They match very well in their body mass index. They match very well in the chronicity of their migraine. Most of them had their migraine for 20 years plus. So 518 patients ended up in the screening. 480 were included in the safety population. And in the analysis, 477 were included because some were disqualified at the screening phase. So when you look at the result, at the primary endpoint being having absence, complete absence of any moderate or severe, not mild, moderate or severe headache, aprogepant did extremely better than the placebo, as you can see here, in 45% compared to 28%. And with the odds ratio of 2.09 and a significant p-value. And when you look at the secondary endpoint with the extended period rather than 24 to 48 hours, aprogepant continued to do way better. And 40% patients have absence, complete headache free compared to placebo in 24%. And then looking at the secondary endpoints, within 1 hour, there was no difference. However, which is the ability to function, functional disability. Within 1 hour of taking the placebo or the active medication, which here, aprocibant, they matched very well. Aprocibant did not do better, but within 2 hours, 3, 4, 6, 8, and almost 24 hours, the people on aprocibant did extremely well, except beyond 8 hours. When it comes to 24 hours, they're almost were equal. For at least for 16 hours after the initial event, functionality was way better than aprocibant compared to placebo. Again, the absence of any headache, because we said there absence of moderate to severe. Here, absence of any headache, including mild, even aprocibant, folks did very well compared to placebo, with a significant p-value and 23% compared to 13%, so almost a double. So safety, both medication or both intervention with the aprocibant of the placebo were quite safe. There was no single serious event. People on aprocibant by numerically had more dizziness. I'm sorry, no, numerically had more nausea, I'm sorry, and more fatigue. But otherwise, they were comparable on all other side effects. And these were not significant. So now we'll talk about the taking the medication once the prodrome happens, and with the goal of preventing a headache. Additional efficacy endpoint, looking at if you stick to the medication, does the frequency and the severity of the prodrome itself gets better or not? And the completive absence of any prodromal symptoms over 48 hours. So the endpoint here is not the headache itself, it's the prodromal symptoms itself. As you said, the sensitivity to light, neck pain, fatigue, etc. People matched in this as well at baseline, whether they have no disability, mild, moderate, or severe disability. They matched very well between placebo and aprocibant, except people in the aprocibant group were slightly higher, have higher chance of having disability at baseline, which goes actually in favor of the active medication, if it proves to be efficacious. Because at baseline, people on aprocibant were likely to have more disability compared to those who are on placebo. So, in terms of the specific prodromal symptoms, whether sensitivity to light, fatigue, neck pain, sound sensitivity, or dizziness, they were comparable whether it's people at baseline taking placebo or taking aprocibant. So, how many patients you would expect that will be able to identify the prodrome? 81% of the patients were able to identify the prodrome within 1 to 6 hours before the headache event. 76% were able to predict that the headache will happen. And the most common prodrome reported in all patients was sensitivity to light in 57%, followed by fatigue, followed by neck pain. So, in terms of the first prodrome, which is sensitivity to light, within 2 hours, there was statistically clear separation between the placebo and the active medication aprocibant, and this persistent in 4, 6, 8, 10 hours, etc. So within 2 hours, the people on aprocibant were clearly separated from those who took placebo in terms of the absence of the sensitivity to light. Those, in terms of functional disability, within 24 hours, patients on aprocibant did extremely better than they were able to function very well in terms of their activity without any much of activity limitation, and 65% compared to 47% in placebo. So that was also statistically significant. Being satisfied with the medication within 8 hours and then within 24 hours, both groups, when studies, aprocibant did extremely way better than placebo, and 66% within 8 hours and 65% within 24 hours. This is patient-reported satisfaction. So in summary, prodromes can predict the migraine headache, and luckily it does predict the migraine headache in most patients, at least 75% to 80% of the patient. And if patients choose to take aprocibant before the headache starts, most of them will do way better if they choose not to take anything and just go with placebo. As we said, we now identify the most common prodrome symptom would be sensitivity to light, followed by fatigue and neck pain. And the effect, the desirable effect, was clear within 2 hours, and it was persistent up to 24 and then 48 hours post-dose in clear, pre-identified outcomes and in patient-reported, self-reported satisfaction. And then functional disability as well was in favor of aprocibant. So that's if we are going to address the prodrome. ACHIEVE, it's a double-blind placebo-controlled trial that looked at the efficacy of the drug, which is aprocibant, in treating the migraine attack itself, the headache itself. So almost 1,600 patients were looked at. 1,300 almost were included in the randomization with modified intention to treat. They were randomized 1-to-1 to aprocibant, 1-to-1 aprocibant 50, aprocibant 100, or placebo. And they looked at the main primary effect, which is pain freedom, which is now compared to in the past, improvement in pain, or pain improvement was efficient for FDA to approve a new acute treatment medication. Now, FDA has changed its requirement to have pain freedom at 2 hours after the first dose, and the absence of the most bothersome symptoms at 2 hours after the initial dose. Secondary endpoint, pain relief, which is less than pain freedom, some pain, but better. Sustained pain relief with up to 24 hours. Sustained pain freedom up to 24 hours, and absence of the aura symptoms now. It's not to the prodrome. We'll address the aura, photophobia, phonophobia, nausea, and vomiting. Additional endpoint that was looked at is the reported outcome, which is satisfaction, functional disability, and having a sustained response up to 48 hours. And also the efficacy by comparing the efficacy of this medication compared to triptan responders before. So again, the demographics matched very well in terms of age, in terms of gender, in terms of race, in terms of BMI, in terms of the severity of headache, whether it's moderate and severe. They matched very well between the placebo and the active medication, which is aprocibant, and also in terms of the distribution of the aura symptoms, whether it's photophobia, phonophobia, or nausea. They were equally distributed between two groups to ensure the randomization was fair. So if you look at the most important primary outcome, which is the pain freedom at 2 hours, aprocibant almost doubled, have a double response at 100 milligram compared to placebo, not at 50, at 100 milligram, 21% compared to 11% within 2 hours. I'm sorry. Yeah. And then looking at the most bothersome symptoms within 2 hours, also aprocibant was favorable at 100 milligram compared to placebo, 37 compared to 27%. And looking at only pain freedom, now we can see pain freedom as a co-primary endpoint, add pain relief. If you add pain relief as a co-primary endpoint, the separation was clear and very huge, almost 4 times better in aprocibant 100 milligram compared to placebo. Okay. Secondary endpoint, which we said having the pain freedom that we got in 2 hours is sustainable up to 24 hours. Aprocibant also did better. Having a sustained pain relief, not freedom, also did better. And as you expect, it did way better than pain freedom at 24 hours, of 40% compared to 20%, almost 40%. So patient-reported outcome, at baseline, they were comparable. At 1 hour, there was no difference. Only at 2 hours, you can see clear separation, which was sustained up to 4 and 8 hours. And that was also, as per the patient reported outcome, was also sustained up to from 2 to 24 hours as well, and 60% compared to 35% in the placebo. So adverse events, as again, there was no major serious events that happened. Severe, mild, or moderate events that happened equally in both groups. There was no statistically significant difference in the most adverse events, except slightly more nausea and being fatigue and somnolence in the aprocibant group, but this was not statistically significant. So given all these, the medications got the FDA approval for treatment of acute migraine headache, and with many other drugs, to be honest, but it's the only medication that got the approval to treat prodromal symptoms because of the Prodrome trial. The Canadian guidelines have included now aprocibant as a first-line medication that you can take even if the headache is mild, with like NSAID or simple analgesics. And also, it is recommended to be taken at the prodromal phase by the Canadian Headache Society guidelines. So with this, I conclude. There is a clinical case. I probably should.
Yeah, we will have it. Okay, thank you so much. No,
more questions?
We'll start with Dr. Maisa first, so we can go in the series, approaching patient with migraine and coming all the way to the treatment with aprocibant. So thank you so much, Dr. Saeed, for this wonderful presentation and highlighting all the clinical features and all the features of therapeutic features of aprocibant. So now, Dr. Maisa, if you can present your case.
I have two cases about patients with migraine. So the first, it's for discussion, with Dr. Saeed, Dr. Wissam, and yourself, Dr.
Yes,
Ashraf.
all of us will discuss together.
So just 1 second. All right. So we have a 38-year-old female who presents with a history of worsening migraines over the past 6 months.
The voice, well, we cannot hear you, Dr.
Can you hear me?
Yeah, we hear you now.
I think I logged out by mistake. Anyways, so she reports headaches occurring 18 to 20 days per month, often requiring medication. Despite using sumatriptan and over-the-counter analgesics, she gets limited relief. She feels overwhelmed by the impact on her work and her family life.
Okay. So, we'd like to have the screen, Doctora. If you can share the screen with us, Dr. Maisa.
You cannot see it. 1 second, please. Share. Case discussion. Can you see it now?
Yes, it's almost coming.
Yeah.
Yes, we can see it now. Yes, go ahead. Full screen.
Okay, so wait 1 second. So this is number 1. This is the case, and the primary diagnosis other than migraine, if we, Dr. Wissam, Dr. Saeed, and Dr. Ashraf, going back to the case, what type of migraine?
Can you go back to the case, please?
Yeah, let's go to the case. So she's 38 years old female with a history of worsening migraine over the past 6 months, and she reports headache occurring 18 to 20 days per month after requiring medication despite using sumatriptan and over-the-counter analgesics. She gets limited relief, and she feels overwhelming by impact on her work and family life. Okay.
We can say she has migraine with burden, with impact on her quality of life. She's using analgesics, triptans, which are second line with no relief. The attacks are 18 to 20 per month, which puts the patient under the classification of chronic headache.
Chronic headache, yes.
And I'd like to hear the opinion of the neurologists, if something else is in mind.
Yes, of course. Based on the presentation and the number of headache days, so fulfills the criteria for chronic migraine, okay, which is more than 15 days of headache, having all the criteria of the International Classification of Headache Disorders, edition 3, with more than 8 of the attacks fulfilling these criteria for the last 3 months. Okay, so this is fulfilling the criteria of chronic migraine, and we need to ask the patient if really he's taking over-the-counter medications, because it was mentioned that it was not responsive even to the analgesics. So even if he's taking, as I said in my lecture, paracetamol or Proxen or any other NSAID, so he might be reverted into a drug overuse headache. And in this case, we need to treat as initially as a drug overuse headache, and then see whether the headache frequency continues to be more than 15 days. Then we diagnose as a chronic migraine. Whereas if he reverts to an episodic migraine with a lower number of headache days, then it's an episodic migraine.
Okay. So
I
I think
agree.
being a female and she's belonged to that particular age group, this will and fulfilling the criteria of diagnosis, this will give us a clear picture. This is a straightforward migraine case.
Especially that she has also medication overuse. It's not only the type of management she needs, it's also treating medication overuse.
Yeah.
So she has both chronic migraine and accompanying medication overuse headache.
So as it was said by Dr. Wissam, taking the history of the medication, the dose of medication, and even the response. So this will tell us exactly how we can build up our next choice of going.
This was the second question, which is already answered.
Okay.
And he also answered, I guess, the next step in managing this patient. I think we have the answers for this case. I will read the second case. A 45-year-old female who presents with a history of migraines that have worsened over the past year. She reports headaches on 15 to 18 days per month, often triggered by stress, sleep deprivation, or skipping meals. Her migraines are characterized by moderate to severe throbbing pain, nausea, and sensitivity to light and sound. She has tried somatriptan with partial relief, but complains of side effects, including chest tightness. She denies red flag symptoms, such as new onset neurological deficits or severe sudden headaches, and she is eager to explore new treatment options. So this is the issue. Again, uncontrolled migraine.
Correct.
What do you think, doctors? The patient is asking about alternative acute therapies since she cannot tolerate triptans. What is the suitable option?
So I see that this patient is eligible for preventive
Surgery.
therapy, due to the high number of headache days and the debilitating effect from the headache from the migraine. I think we should offer her prophylactic treatment.
What about acute therapy?
Of course, and because of the side effects of the triptans, as we said before. So now the era of the GPANs and anti-CGRP medications. So we can offer her one of the available medications. Okay, the Ubrelvy is one of the best drugs.
These are my two case discussions. If you'd like to go to the second.
Okay, thank you, Dr. Mesa. And this is exactly the real world clinical case that we encounter in family medicine and primary care. So thank you for choosing these kind of cases. And now we'll go to Dr. Wissam. I think you have a case, so you can present,
One
please.
second, please. One second to share.
Okay. Yes, we can see the screen, full screen now.
So this is a 28-year-old young woman. Sorry. I don't know what happened here.
Yes, we can see it.
I cannot see the video. Oh, it's no problem. It's a 28-year-old young woman that I saw maybe a week ago with no known chronic diseases. She presented for 2 years history of recurrent episodes of headache. It's always preceded by an aura characterized by seeing light flashes for around 15 minutes. It's usually unilateral with shifting sites, pulsating in nature, and associated with nausea, sonophobia, and phonophobia. So the episode lasts more than 4 hours and does not respond to over-the-counter paracetamol. It recurs 1 to 2 times per week. The patient cannot recognize any specific trigger for the headache, and the patient has not taken any migraine-specific medications or preventive therapy before. She did the brain MRI 2 years ago when she was investigated and was reportedly normal. Her physical examination is unremarkable. So what do you think about the diagnosis first?
This is acute migraine headache.
So it's a clear case of a classical migraine with aura of the episodic type, because the number of headache days does not exceed 15 days per month. Do you think that we need to repeat the MRI or to do any further investigations before confirming the diagnosis?
No.
No, of course no. Okay, because it's very clear. There are no alarming signs, no red flags. The MRI was already done and was normal. Okay, nothing has changed over the last 2 years. It's the same characteristic headache, the same features, the same frequency. Nothing has changed. The only thing that is that the patient is now seeking medical advice, okay, to look for the best treatment for her condition. So what do you think? Should we offer her an abortive acute treatment, or should we put her on preventive therapy? What do you think?
I will give my opinion.
Yes,
As long
go
as
ahead.
she never took migraine-specific treatment, why put her on a daily medication for prevention rather than trying abortive therapy and following up with her headache diary and her headache calendar? Along with the lifestyle advice, as we mentioned before, we need to check her triggers, avoid them, try the abortive therapy, and then we can decide.
Actually, this is what I did. I asked her, I explained to her everything about migraine, about the treatment options. I explained about the preventive therapy and the abortive therapy. And since she did not take any abortive therapy before, and the frequency of the headaches, as she said, 1 to 2 per week, so she might benefit only from abortive therapy, especially if she can adjust her lifestyle, avoid triggers. I asked her to concentrate on a possible trigger that she does not know first, to adjust her lifestyle, her sleep, her meals, everything, and to come back to me maybe after 1 or 2 months with a migraine diary to check for the frequency of the headache attacks and the responsiveness to abortive therapy. I put her on ubrogepant, and when I see her on follow-up, I will decide whether I need to really put her on a preventive therapy or not.
What is the problem, Dr. Wissam, of putting her on both abortive and preventive in this case from the start? Shall we wait and see her response for the acute and then decide?
There is no consensus for this. Based on the recommendations, any patient who experiences more than 4 or 5 days of headache per month, he's eligible for a preventive therapy. Or even less than 4 days, but the headache is very severe and associated with severe disability. Some patients say that, for example, they lose 1 or 2 days of their life per month because of the headache. In this case, I would suggest, of course, starting them on preventive therapy. But in this case, it's borderline. The patient's complaint is not so severe, the severity of the headache. So that's why I decided to try first the abortive therapy. If she complains, for example, of 4 or 5 episodes per month, and they are very responding within 2 hours to abortive therapy, she might stay only on abortive therapy, or else I will put her on preventive therapy. So it's case by case.
Excellent. Yeah. Any other case, Dr. Wissam?
No, that's it.
Okay. Thank you so much, Dr. Wissam. So this was a good, interesting case. Dr. Said, please, it's your case to present.
Bismillah. Is it clear now? You can see it?
Yes, clear.
Okay.
We can see it.
So this is I'm a stroke neurologist, so I get to see quite good number of patients with a stroke. So this lady is 52 years old lady who had a medical history of hypertension. She had a remote ischemic stroke when she was quite young, at 30 years old. She had no disability related to her stroke. She recovered very well. The stroke mechanism was never identified. She was thoroughly investigated by other colleagues in other centers, and there was no clear mechanism to explain why she had the stroke then. I myself, when I saw her, I did again thorough workup to find a stroke mechanism, and I was not lucky. I couldn't find anything. So I called it cryptogenic stroke. However, likely migrainous infarction, because she clearly remembers she had a bad 2 days of headache associated with her event. She also has established migraine with aura since she was 15 years old. She get daily headache now for almost 2 years, almost daily analgesics that she takes. She has a quite poor quality of life. She's started to introduce her social interactions. She stopped all exercises. She denies any depressive symptoms. Her previous prophylaxis included amitriptyline up to 50 milligram, topiramate, valproic acid, pregabalin. She tried botulinum toxin only for 2 sessions when I saw her. So it wasn't enough yet to say whether it's effective or not, but she reported some relief. But she had to stop it because she has no insurance and she had to pay for it. It was a bit expensive for her. She cannot take triptan, given that she has hypertension and a previous ischemic stroke. So instead, she takes a combination of paracetamol, codeine, and caffeine 2 times per day and sometimes up to 4 times. Her exam is normal. Her MRI show a small, tiny little ischemic stroke. That's the old one we already established in her left frontal lobe. So I started telling her that she probably has a combination, chronic migraine and analgesic overuse headache or medication overuse headache. And I educated her about that and that she must cut down on her daily medication use. And I prescribed her aprodipant as a PRN medication now that she's happy with good insurance coverage. And also I resumed her back on botulinum toxin sessions as a preventive therapy. I saw her first time within 2 weeks. She was quite happy with her aprodipant. She did not report any side effects. She said within an hour or two, she quite have dramatic improvement in her headache, and most of the time she becomes headache-free. She reported no major side effect. I saw her again in 3 and 6 and then 12 months. She continued to report quite improvement in the frequency of her headache, given that she's taken now botulinum toxin on a regular basis. She still has maximum 3 to 6 headaches days per month. But for her, this is a paradise. She's way, way better than she used to be before. And she's clearly telling me she had never felt the same in the last 4 years. She's back in her social interactions and she started to go to a gym twice a week. So there is a few messages from this case. We must almost always consider medication overuse headache. We shouldn't overcome that. It's a major contributing factor to the severity and chronicity of the headache, especially in patients with chronic migraine. Trying an effective preventive therapy should be given appropriate time, because 2 sessions of botulinum toxin is not enough to determine whether it's effective or not. And in her case, she has clear contraindications to triptan. So luckily now we have alternative, which is the aprodipant. So yeah, these are the main 3 messages I thought this case could present to the audience.
Okay, thank you so much, Dr. Said. Anything else you would like to add?
No, I'm good. Thank you.
Okay, thank you so much. So I think we'll start we'll open the questions now. Already I have received a couple of questions. I think we'll start by you, Dr. Said, because this is related to what you have said as a take-home message from your case. The medication overuse headache, how long the patient should be on that particular medication, for example, in say Dr. Tan, to label the patient that he's getting into the overuse status, and what are the most common medication that causes the overuse, and how to prevent it and how to treat it.
Got it. So as per the definition, and we have to remember the definition is established not to define every single case, but to define patients involved in clinical trials. So as per definition, you have to have at least 3 consecutive months of 15 plus days of use of simple analgesics, or 10 days of using triptans to justify to have a medication overuse headache. So that's the main definition. Do we stick to it? If someone doesn't take it for 15, take it for 13 days. I would still call it. Although this particular patient is 3 days short, but for me, he fits in because I said these numbers are arbitrary, used in clinical trials to identify patient and include them in clinical trials. It doesn't identify every single patient with medication overuse headache. The most common medication are simple analgesic like paracetamol, acetaminophen, non-steroidals, and triptans are the most common medication I'm aware of. Does some patient unfortunately abuse opioids? Yes, but in my limited practice, especially here in Saudi Arabia, this is a very, very small number, alhamdulillah. I haven't seen much in Saudi Arabia. And the best strategy is education, then education, then education, and don't make the patient suffer alone, waiting to start appropriate preventive medication. Choose appropriate preventive medication, appropriate for this single patient, and start as early as possible.
Excellent. In your practice, Dr. Saeed, do you come across medication overuse headache, referred to you by primary care physicians? Because in primary care, what we use NSAIDs and triptan, very tremendous. We use it in abundance. So I think this primary care is the point where you might get more cases of medication overuse headache, or those patients who are using it by themselves without coming to encounter with primary care. So do you get this kind of cases coming to you from primary care? The overhead.
Excellent. Actually, the literature has answered this already. Most patients are self-used. Most patients go and take this medication over the counter without physician prescription. Actually, if we go back to the diagnosis, most living people with migraine have never been diagnosed with migraine. They have had this headache for a considerable number of years in their lives, and they don't even know they have migraine. So yes, I get the referrals from colleagues in family practice or other specialties, but I would honestly say most patients are self-medicated on this medication.
Thank you so much. Dr. Misa, there is a question for you. Treating migraine with mental disorder like depression, anxiety, or sleep disorder, what is your approach as a family physician to this type of complicity of case, migraine plus mental disorder?
As I mentioned before, migraine can be the reason of developing depression, anxiety, or even both. So we really need to know whether the patient has a baseline psychiatric disorder. It's only a comorbidity from migraine. If we treat the migraine, the headache is better, the mental status is good, this is what we need. But if we have a baseline disorder, low mood, and the typical criteria and the diagnostic criteria are met, we also treat either anxiety or depression with the suitable way, lifestyle or real SSRI treatment for the mental illness itself, and also to help improve the migraine attack. So it really depends on the case. It's a patient-centered approach.
Okay, thank you so much. Dr. Wissam, how the management of migraine differs if the patient have aura or doesn't have an aura? So what are the different methodologies? What the management
Actually,
difference?
there is no difference in the treatment, the approach between patients with aura or without aura. 30% of patients only have aura, 70% don't have aura, but the treatment is the same. We usually advise the patient to take the medication, for example, the abortive therapy, as early as possible, because we know that the medication, if taken early on during the aura or even during the prodrome, then there is a very high likelihood not to progress into the full phases of migraine. All patients who wait until the headache intensity increases and intensifies, when they take the medication, then the effect will be very minimal. And this is we say this to all patients when we advise when to take the abortive therapy.
Okay, thank you so much. I think this was a question was delivered to directed to Dr. Saeed. Does the early onset of taking aprogepant will improve the response? I think it's almost the same. Yes. Dr. Saeed, can aprogepant be used in combinations with triptans and NSAIDs?
Yeah, there are no reported interactions. So yes, I tell patient if you want to use, you can.
So it will be add-on, whatever the patient already on.
I would recommend to stick with one, whatever works. And I have to be honest, I know we're sponsored here by AbbVie, but If a patient is happy with using simple analgesic, then it's simple analgesic, provided that he does not overuse it. However, if the patient is quite bothered now by the prodrome and he doesn't want to migraine if that's a big thing for him, he doesn't want the migraine to happen at all, then his only option is the Aprogepant.
Okay, very good.
Just, as I said, simply having a neck pain. I'm having 6-8 hours of neck pain. You know what? I know the migraine is coming because, as I said, almost 80% of the patient, they know this is coming. Their only option is Aprogepant here.
Okay, Dr. Sam, CRGPs in general, it's a new medication that has been introduced, not only for the neurologists, but also to the primary care. And now widening the scope of primary care and family medicine, now we are in a position to use these medications, with full confidence. What is your advice? Because there is some kind of reluctancy to use it by the primary care physician, even by the patient themselves, regarding the safety, efficacy, the side effects, and so forth. So how do you look into these kind of issues and how we can tackle it?
Actually, based on the currently available studies and the literature, okay, at least until now, okay, the unmet needs that I talked about, okay, from the other old medications like triptans and NSAIDs are not present in the currently available anti-CGRP medications. And this is a very important advance in the treatment of migraine, especially that we now know what is the trigger of the migraine cascade. CGRP is one of the neuropeptides involved or trigger the migraine, among others, and studies are still ongoing to find other causes. Maybe we have another molecule called PACAP, the pituitary adenylate cyclase activating peptide, that has shown also to play a role in the activating cascade of the trigeminal vascular system. So the advances are still ongoing. And this is what we have reached now. Okay, all the medications started to be FDA approved from 2019. So now we are 5 years, okay, after the first approval of the first drug. And from our experience until now, we've seen very, very, very good results. I have patients that say, I've been complaining from headache for 15 years, and this is the only time that I can say that I am living.
Yeah.
So it's life-changing. Really, it's life-changing.
And improve the quality of life.
So that's why, of course, I advocate for these medications.
Okay, Dr. Sam, when you start moving the patient from first line to second line therapy, do you go with the maximum dose, advise the patient to maximum dose, or you advise the patient to go for combinations, for example, NSAID, triptans, and others?
You mean for the acute treatment?
For the acute treatment, yes.
You mean that whether I try to increase the dose of the previously medications and then change?
Yeah, if the patient was on NSAIDs, for example, and he has an acute attack, and he was using a certain dose, do you recommend to increase the dose, or you shift the patient directly to the second line, for example, triptan CRGPs?
Depends. Usually in NSAIDs, usually the dose that's taken is a common dose. That there is no need to increase the dose. For example, naproxen, we give 500 milligram, and it could be taken another 500 after 12 hours. So usually it's not, we don't increase the dose of NSAIDs. Triptans, maybe, yes, after 2 hours, if the patient does not respond, okay, he might take another dose. For example, sumatriptan, if he takes 50 milligram, he can take another 50 after 2 hours. But usually it's case by case, depending really on the responsiveness to these medications, on the side effects, on the patient profile, on the comorbidities. So previously, we haven't the choice to choose between the medications. Okay, but now since we have this this choice, so based on each patient characteristics, okay, we decide whether to keep him on the old medications or to immediately move to one of the new drugs.
Okay, thank you so much. I think this is the same questions you have answered. They have the similar questions. We'll be going to Dr. Saeed. How do you choose among the different types of CRGPs in the management of migraine, whether it's acute or chronic?
Okay, I have to be honest. For me, my experience with anti-CRGB is ease of use and my familiarity with the medication. So for the time being, I only use one preventive, which is the monthly injectable. I use Emigality. For the acute, I only use one medication, which is Aprogepant. These are the only two anti-CGRPs I've been using in my practice.
Excellent. I think this was all the questions.
So we are limited, and so that's why in the government hospital we are very limited in the number of medication we have as formulary.
Okay.
I can add something in it.
Please go
For
ahead.
this question, we can offer the patient the options of medications because now we have oral medications, we have IV medications, and we have subcutaneous medications. So some people prefer to come, for example, once every 3 months to the hospital and take the IV drug. Others want to take the once monthly subcutaneous injections. And some patients, okay, don't like to take any prick in their body and they want only the oral medications on daily basis. This is for the preventive therapy. So usually I offer the patient all the availables and I see what he prefers and go with it.
I think, Dr. Wissam, in the era of Ozempic and Manjaro, there is no more terpinophobias. People are not afraid of injections anymore, so they can have it. All right, I think we have finished almost all the questions, but before we close, I would like to have a single statement from each one of you as a recommendation and take-home message to be delivered to primary care in managing patients with migraine. So we'll start by Dr. Maisa as a family physician. What would you like to say to your colleagues from your experience?
I'd like them to take the summary of my presentation, take a very good history to label the patient as migraine, keep the differential diagnosis, give the patient the opportunity of a real good beneficial medication, follow up with the patient. Continuity of care is really important because we cannot reach what we want in one visit. It needs several visits to reach what we want and what the patient is seeking for.
Okay, excellent. Well said. I think all the things goes to the primary care
There's nothing
physician,
to say.
except the last part, which is said continuity of care. This is a message going to our colleagues in the secondary care. So to refer the patient back to us. Thank you. Dr. Wissam, تفضل.
So Dr. Maisa, I think she said everything that we should do. Okay, take a very detailed history is very crucial. Okay, to have first of all a very solid diagnosis. Okay, especially that patients with migraine have a lot of comorbidities. Most of the time, sometimes they have the tension type headache. Sometimes the headache is triggered by the case of chronic anxiety or depression, and we see this a lot in our clinical practice. So reaching a very solid and very sure diagnosis is the mainstay to treat the patient.
Thank you so much. Dr. Saeed?
Yeah, there are many things to address about migraine, but I'll stick to one single thing. I'll stick to the anti-CGRBs in general. I'm not going to talk about any one specific. I think we saw how this new era came that shifted the care of morbidly obese patients from laparoscopic surgeon to endocrinologist. Yes. I think there is a huge chance with the anti-CGRP to shift most of the care from neurologist to primary care physician. The argument is, and I want to stress on this, that as far as I know from my limited practice and as far as I've gone into through the data, all the anti-CGRBs are extremely safe, except pregnancy. That's the only exception I can consider, which is pregnancy. So, and most of them are effective. I believe in I have an opinion that some are effective more than the other. But going into practice as a primary care physician, you're going to be seeing the patient more often and feel comfortable that even when you experiment with these new drugs on your medication, you don't have to worry about anything serious happening to him. So that's, I think, is a huge, huge chance for primary care physician to take over the care of migraine patient from neurologists, as the endocrinology took it from the bariatric surgeons.
Thank you so much, Dr. Said, for this inspiring, statement for primary care physician. So I think, we will conclude by saying, Migraine is very common conditions that encounter the primary care with a lot of challenges. And now we have learned by all this presentation that proper taking history and make sure that we are dealing with migraine and classification of migraines in terms of episodic and chronic. And we have learned that more than 90 are episodic and less, maybe 10% are chronic. And then we can use, make sure that there is no secondary causes for a headache, and make sure that you are dealing with migraine. And then we have the different classes that we can use, and say triptans and the new anti-CRGP, which is very promising for us as a primary care physician to learn more about them and to be confident to use them, because it showed, like abrogepant has been shown that it is quite efficacious, tolerated by the patients, safe medications, improve the quality of life and decrease the functional disability of patients with migraine. So if we can do something good for patients with migraine to improve quality of life by using this medication, so this is the best thing ever we can use to make sure that we are doing the best for our patients and doing, something of a real value to their life. So with this, ladies and gentlemen, I would like to thank on your behalf our guest speaker, Dr. Maitza Khalil, Dr. Saeed Al-Ghamdi, and Dr. Wissam Yamak for their wonderful contributions and the rich information that we have highlighted in these scientific sessions, and getting all these clinical parts, which is touch the reality of our clinical practice, have added a lot of values for our theoretical part to be implemented on the real world practice. So I would like to extend my thanks to Abhi for giving us this wonderful opportunity to be together. And Fadal, Dr. Saeed.
I'm just, because I've seen, I'm sharing my email in the chat.
Okay.
Please, anyone who has any specific question about specific patient or a relative, please feel free to email me at any time. I just put it now in the chat for the audience.
الله يعطيك العافية. Thank you so much. إن شاء الله يعني صدقة جارية. الله يعطيك العافية. So, ladies and gentlemen, I would like to thank the Saudi Society for Family Community Medicine, and thanks to the IMC Family Medicine Department, and continuing, inshallah, along with you, ladies and gentlemen, different episodes are going to come next month, inshallah, in the IMC Family Medicine Club. A lot of thanks to FEXS, ملتقى الخبرات لتنظيم المعارض والمؤتمرات, for this wonderful organization. Looking forward, inshallah, to see you next month in another episode, in another challenging clinical entities that touch our clinical practice as a family physicians. Thank you so much. Wassalamu alaikum wa rahmatullahi wa barakatuh.
سلام.
يعطيكم العافية. شكرا جزيلا.
Thank you Allah.
شكرا لكم جميعا.
شكرا دكتور سعيد، دكتور وسام، دكتور
يعطيك العافية.
ياسين. في أمان الله.